You're listening to Teats and Ash, the show where two real-life providers get real about health habits, wellness, and the broken healthcare system. We're here to educate, empower, and entertain you. One appointment-free episode at a time. This is healthcare without the bullshit. Well, let's talk about how we got here. Okay. How did we get here? So I'll tell you how I got here. Back in the 1900s. In 1995, I started out as a medical assistant for an OB/GYN doctor. He was like freaking amazing. He was like the dad of everybody in this area, and he grew everybody up in healthcare and medicine. He did little man thing and said, you should go back to nursing school. Okay. So I did. I went back to nursing school, graduated, became a nurse, worked in med-surg, PCU. Every weekend because we're the weekend warriors. So anyway, and then went to the ER one day and I was like, oh, I found my people. Oh my God, they're ADD like me. And if you didn't have ADD before you started in the ER, you were going to get it eventually just because of the way you, well, that's where all the unmedicated ADD. Yeah, that's where we live. It's amazing. So, and then I did trauma for a while, did trauma education for a while, and then did trauma again, and then went up to PACU. It's where all ER nurses and ICU nurses go to die is in PACU, retire. And so, and then went back to nurse practitioner school because I thought, oh, I could totally make a difference. I love ER. During nurse practitioner school, when I was working on my master's project, we had to pick a subject. Like a lot of people pick like urine catheter infection and all that mess. Yeah, we had to carry it all the way through because they wanted you to DNP it. They wanted you to do it and eventually get published. It was just way back 1,000 years ago. And so I had looked up direct primary care back then. I was like, ooh, this is novel. This is neat. Because they had taken out insurance for primary care. And so fast forward to working in the ER with you. I'm hearing registration tell these patients they get like 95% off of their freaking bill if they just pay $200. I'm like, there's no way. I didn't tell them 95%. No, the registration would tell them like 90 to 95% would come off their bill if they just paid $200 flat. That's ridiculous. And that's how it pissed me off to get me started this thing because, working in the ER, we're seeing where we were and the fast track, or even in the main, we're still seeing primary care patients, and they are coming in droves because they can't get in with their primary care provider. They cannot see them. They'll say, okay, well, you can have an appointment in 6 weeks, or you can go to the ER. And of course they're going to go to the ER. They're sick now. They'll either be dead or better in 6 weeks. So that's what started this thing for me is, being able to provide that in just a better environment because you turn a burn in the ER.
Yeah. That's I didn't start as a CNA, but my mom was a nurse anesthetist. And so I finished school in 2000.
Me too.
Started working PCU for a year because at the time, no one started in the emergency room as a new grad.
Never.
Then I went to the emergency room, went to a trauma center, did trauma for 7 years, did a travel assignment, and started working.
I didn't travel.
And did a very short stint. So we did that for trying to figure out what to do, and then went back to school. So then I worked in another emergency room that was really low key for the military. And going back to school was super easy. Went back to school, finished that in 2010. But I had always thought I was going to do emergency. Even though my mom was like, you should probably go to CRNA school. And I'm like, oh, wow, that's so boring. I was 28 years old. I was like, no, the OR is so boring. But at 50,
I know, right?
my knees are like, God, it'd be great is if you were sitting down and watching someone breathe and making sure their vitals were great.
So you use your ER brain here.
Yeah. Well, I chose poorly, so I went to the emergency room.
Yeah. I chose poorly.
No, it was great. And it was great. It was really hard. So I did that, and I'm still doing that. But you're right. Yeah, you see all these patients that come in for primary care. I mean, just this week alone, I've had medication refills for seizure medicines in the emergency room.
Stuffy nose.
Family of 4, stuffy nose on the weekend. This is not an urgent care.
It's a poor utilization of resources
Right.
when you use an ER for primary care.
In their defense, alone in this clinic last week, I had 2 patients that were signed up because they were hospitalized, discharged with a chronic illness, instructed to follow in primary care. They have insurance, can't see anyone until October.
I had one the other day that can't get in until February.
Yeah.
Oh my
And
God.
so she's like, I just was diagnosed with this life altering, disease. And they're like, thoughts and prayers. Here's 30 days of medicine. Then what?
Good luck to you.
I mean,
But they'll come back to the ER.
they will. Always
Because they
have
can't
to.
get in.
Luckily, you can get in here. And she is able to kind of establish, and we can get those meds, going before she runs out. That it's just wild when you talk to people and they're like, yeah, I can't get in until, December or whatever. What happens in that interim?
Yeah, you're right. People either get better
Or they die, or they just are like, all right, well, I'll just thoughts and prayers this diabetes until December.
rub some dirt on it, it'll be fine.
And then toes go missing. I mean,
Yeah, and I have patients who have come in here who have full insurance and they can't get in to get established with their primary for 6 months, and that 6 months comes and goes, and they say, "Oh, I finally got established with my primary. I'm gonna cancel my membership." I'm like, "Okay." They come in 2 months later, like, "I can't get an appointment with my primary."
well, they had their first evaluation, but they can't get in after that.
And it's not even the provider's fault. It is not the provider's fault. It is insurance mandating us how we take care of things and do things.
It's the system.
It is the system.
The
It is
system.
gross.
The system has failed humanity.
Absolutely that. Because it's checking a box, it's following an algorithm, and it's not really, because not everybody fits in a box. Because we have to take care of the patients how we best know how to take care of them, but yet we have people up in insurance industry who have no medical background whatsoever saying, well, it doesn't fit that box, and no, so I'm not going to do that.
Right. Yeah, that is, it's so disheartening when you walk in to a room, like in an emergency room setting, and you're like, it says, whatever, chest pain or something that they checked in for, and you go in and you're like, hey, I'm Tarra, I'm the nurse practitioner. Tell me about your chest pain. You're like, I've been coughing. You're like, oh, okay. So then your brain immediately is like, not chest pain, no, but chest pain, but not chest pain,
not that chest
not
pain.
cardiac chest pain. And so you like, okay. You break it all down. You find out they've been coughing. Their kid was sick 2 weeks ago, whatever. And the lack of information for them, like they don't know
The billing and the coding and all the things.
We were talking about insurances, and we're talking about how patients don't.
We don't have, and we don't even know how our own insurance works. So I give this spiel to all of my patients when I talk about cash-based pricing versus insurance-based pricing. My daughter, who was probably, I think she was 8 at the time, I don't know, she's 8 or 9, she broke them, out of her wrist. And so I take her to the ER that I had worked in. I don't have insurance. Take her in there. We see her, and so we get her seen. She gets x-rayed. Yes, it's broken. Yes, broken.
Broken.
I was not just fractured. Broken. It was broken. Is it broken?
And fractured.
Or is it fractured? Anyway, so
Thank God it wasn't broken.
Jesus Christ. So we get in, we get admitted, we go upstairs, we see the pediatric orthopedist specialist the next morning, and we have surgery. And then we get discharged home, I think later that night or even the next morning. I cannot remember. I just remember sleeping in that god-awful recliner. It was terrible. Yeah. Anyway, so I get a bill from hospital, and they send me this bill for roughly $64,000. It's like $63,000 and change, and this is without insurance. And I'm like, oh, y'all are so cute. I need the cash price bill, please. And they're like, well, do you qualify for Medicaid? I'm like, no, I don't. Can you just send me the bill? So you have to fill out the Medicaid form because, of course, they're going to get more, if you have Medicaid insurance, whatever. So I fill it out, send it back. Oh, yeah, you don't qualify. So we'll send you the cash price bill in a couple of months. I'm like, okay. And the receipts. So then I have the receipts. And then they sent me the cash price bill, and it's like $5,400 for the entire stay, for the pre-op, OR, PACU, anesthesia, all of it. ER, everything. 50. So I carry a catastrophic policy and pay about $300 and change for that a month for my family of 4 for like accident, vision, ICU, and cancer. And so I submitted her claim to them, and they sent me back the check for $1,800. So my total out of pocket's like right at $3,600, which you can still make payments on with the hospital. You can pay $200 a month and knock it out in like, 18 months?
So I do, and I think that's amazing. And you and I are talking to so there's, especially when you work the emergency room, you see all the socioeconomic groups,
Every one of them.
But it is not like I'm never gonna recover from this, right?
64,000?
64,000. I'm never gonna recover ever. 3,600. I can make this work. Even as a college kid, once I looked at it and figured it out, had time to process it and figure out like, oh, I can do payments, perfect, things like that. Like that is an affordable healthcare. That's an affordable.
It's not
scenario.
surmountable because you're looking at $64,000 and you're bankrupt yourself.
Absolutely.
Trying to get this pace.
Some Americans,
But they don't tell you.
some Americans don't make 64,000. So yeah, I could see, but you're right. None of that information is distributed to the general population, and you really have to search it and dig for it to get it.
And I didn't even know it until I had stepped out and did this.
I didn't either. I kind of did. I had a friend that had figured this out early in our lives, and I figured out that.
And so it always sat in the back of my mind.
So that is a lot of healthcare that we have witnessed evolution, that we have watched evolve. I have 25 years of, you do too, you have more, you have 30 years of healthcare. You have watched healthcare evolve.
It's gotten horrible.
And you're right, we really haven't improved.
No, it's gotten worse. It's not gotten
I
any better.
feel like for a period of time, we did have this evolution of not seeing as much primary care in the.
I don't know when that was. I take that back. Maybe in like 2007, 8,
Yes.
kind of that era there.
8 to like 12.
Yeah, it was okay.
It was.
I was seeing sick ass people. I wasn't seeing.
Correct. And you know, that maybe just because of how the
Where we
placement was, but it did seem like I was doing less primary care in the emergency setting at that time, in this short period of time frame. And then we just right back into it, where we're everyday medication refills, stuffy noses, my toenail has a fungus, I have an ingrown toenail.
My back has been hurting for 5 years. Different about it today. I just can't take it anymore.
Right.
Have you seen anybody?
You know, back pain's kind of tricky.
It is kind of tricky. But for 5 years, you've survived that emergency.
Treacherous. So I take back pain with a grain of salt unless we've seen them like 8 times in the last 3 months. Then you're like, okay, maybe we can stop looking for all the zebras of back pain. But yeah, so I don't know, changed in society that we kind of nosedive. Maybe it's going to wax and wane again. Maybe we're going to come up. Maybe people are going to realize there's more direct primary care. No, there are not.
Yeah.
What is
it was how, yeah, because people still don't understand
people
it.
still
Know
don't
about it as
understand.
much.
Yeah. So, well, nobody, and if you ask patients, like, I mean, not everybody has primary care in general, and especially the young groups, like the younger population. I feel like they should
get it.
I think.
I mean, they should understand it. They should understand that you don't need to have this expensive ass insurance to get primary care.
And maybe high school needs to like have a little life class.
They don't even teach them how to do life. They don't even know how to write check. They don't even have to sign their name in the car check. But seriously, we have to uncouple primary care from insurance services.
Yeah.
Because you should be using insurance for catastrophic things. That's essentially what insurance was made for in the first place. I mean, you use your car insurance if you get a car wreck. You don't use it for an oil change, for changing your tires, for changing your windshield wipers, for the basic stuff.
Right.
Because eventually things wear out and you have to take care of them. Same thing could be said for primary care.
Right.
And the disgusting part of primary care is you have insurance saying, you're going to ask for $150, but we're only going to reimburse you as a provider with $32 for this visit. So that's where you're having to turn and burn and see patients every 15 minutes because you have to make your overhead. Right. You have to make your payday too. So we are killing ourselves in primary care under an insurance umbrella, but it's not that great because you can't see a patient in 15 minutes.
Well,
and what care foundation?
So you go in for, blood pressure medication refill and you walk in and the patient's talking to you and all of a sudden, and you're like, hey, so how's everything going? Blah, blah, blah. And you turn around and the tears, they're crying and you're like, whoa, what's happening? And then
What is that?
that moment, like I have to sit down, I have to talk. And so on the other platforms, like you lose the ability to do that, or everything of the rest of the day gets worked, right? Mm-hmm. Now I've spent 45 minutes with this non-critical patient that was supposed to be a medication refill, but then I found out that, their dog died yesterday, and it was their only child's dog or something of that nature. And you're like, wow, this is like developing into this whole event that has nothing to do with blood pressure. And I can't just be like, listen, lady, I can't be talking about your dog today. I ain't got time for that. So that's not how healthcare works, right? No, you sit down, you comfort because you're genuinely decent human being. And in an insurance-based primary care, well, now everybody that comes behind them,
And you gotta apologize.
they need to apologize. And it's scripted, by the way. That's the first things you do is you walk in and you're like, I'm sorry for your wait. Of course, I can't divulge any information to the next
No.
this whole thing happened. No, I'm just like, sorry, I'm late. And it looks like you are the problem. Like I've been chilling with my
I'm
homies
gonna sit back here,
hang
play
out with the staff. But yeah, when it has nothing to do with that, or you receive 74 phone calls in between patients, there's a lot of things that go on
There's tons of stuff that goes on.
that patients don't understand, which they shouldn't have to. I get that part, but when you do, that's the difference between DPC, direct primary care, and just primary care insurance based.
We're still doing all the things that a primary care does. We just are allowed to take a little bit longer.
We're allowed. That's right.
We have the time to take with you.
We do.
And another thing that we do behind the scenes that a lot of people don't know about is when you come in here and we see you and we tell you we're going to get all these things taken care of for you, we're still working behind the scenes after you leave, like prior authorizations and appeals.
Yeah. How many phone calls you have to make to get that done? Or how many clicks does it take to go through the website to get that done? And then you got to pull this record, and then they want to know this, and then they want to know that, and then you submit it. And then it's like playing, like volleyball, like you serve it. I mean, I'm just hanging out, waiting for them to serve it back to me. So I can't do anything until they send it back and tell me either yay or nay or what they want.
And I feel like it changes every 3 months. I feel like we got a prior authorization 3 months ago. Well, now the parameters are different. So now guess what? Do
Or
your PA.
they don't even care
No.
about what was said prior. So
Yeah, we just start over. So you send the prior authorization online, and then you send that and it says, we're going to come back to you later. Then they send you a fax over and you have to fill that out.
Yeah.
And then you have to print out the chart and send it with that. And then they send it back and they say, oh, no, we're missing this, that, or the other. And you're like, it's right here. I just wrote that down for you. It's even in the chart. They just automatically deny it right out the gate.
Well, I think it's AI now.
Oh.
You pick the words. I think they do.
I'm going to pick the words all right. I'm going to pick some little good words.
That's why they're doing.
Yeah, well, it's going to be.
Eventually they'll be like, oh, Ashley sent us something.
Actually, call us a,
You know what the AI is going to be?
3 F-bomb rule.
Yes,
Actually.
there's just 3.
We had a trauma surgeon that said that you got a 3 F-bomb rule in this trauma, or you're intubated.
Yeah.
We know you're hurting. Trust me, we get it.
You know what I want you to go through? What were our numbers about how many primary care physicians? How many
So in Escambia County, there's 326,000 patients in Escambia County. And there's roughly about 250 primary care providers in Escambia County. So when you divvy that up, that's about 1,300 patients per provider.
So
that's why you can't get
how do you possibly get an appointment for a stuffy nose if the provider has 1,300 people on their panel?
You're saying 30 patients a day.
I'd say 30 when all of the primary cares are like, yeah, girl, no, ma'am, it's like 40.
40.
I get it. I mean, probably.
I mean, we were seeing that many patients in an ER turning and burning in a 12-hour shift. But we have big workups or bigger workups. We have a lot of stuff at our disposal. But yes, in primary care, they're seeing 30 patients a day.
That's another thing. Like, why do you think your primary care provider is not curt, but tries to direct you back to why you're here? I mean, not that they don't want to hear about it.
They absolutely do care. They really do. They just don't.
They still got 27 other patients to talk to today.
I have a lot of patients who would come in here and say, this provider just sits on his computer and never even looks at me the whole time we're here because they're busy crossing T's and dotting I's and checking boxes and making algorithms because insurance will come back and say, well, you've got this patient on a diabetic medicine. They need to be on statin or they need to be on an ACE inhibitor or blah, 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 blah. And
but you just forgot to add that to the documentation. Or you didn't
know that. I mean, can we just do some lifestyle changes first? I mean, we have patients who we don't start them on statins right out the gate when their cholesterol's through the roof. We do lifestyle changes first, and we have very good success with it. We don't have to start them on a perfect statin right out the gate.
No, I mean, you can't.
But if you're in a, you have time. You don't have time to talk about nutrition and how to change things.
People have good intentions of providing wellness care. I just think that, one, I mean, put the onus on a patient. Let's talk about that. Oh God.
The best piece of advice I've ever heard is don't do more for a patient than they're willing to do.
Right. I mean,
I'm not going to chase you down and make you do something and hound you about it. I'm going to suggest this is my recommendation. And if you choose to do it, great. If not, great.
I always tell patients, they're like, I offer this treatment or this test. And they're like, I have to do that? And I'm like, I mean, it's not prison. Nothing. Like, I'm not gonna like shackle you to the bed and wheel you there like against your will. That ain't what I do. But yeah, that's what I mean. That's standard care. That's kind of like where we go from here.
But the same thing can be said for your own health. You have to take care of yourself. If you decide not to take care of yourself, if you trade your health care for convenience or giving somebody else the responsibility of taking care of you,